Good afternoon. I'm Helen Branswell, a senior writer on infectious diseases at the health and science news website STAT, and I'm the moderator for today's panel on dengue. 2024 has been a record-breaking year for dengue cases globally. Late last year, the World Health Organization assigned dengue an emergency response grade of 3, its top level for public health emergencies. Today, our esteemed panel will discuss the problem that dengue poses and the tools that exist to combat its spread. Joining me are, to my immediate right, Dan Neefsey, an associate professor of immunology and infectious diseases here at the Harvard T.H. Chan School of Public Health, Marcia Castro, Andelot professor of demography and chair of the Department of Global Health and Population at Harvard Chan, Guillaume Leroy, CEO and member of the board of the directors of Engine Biotech. And joining us remotely from Puerto Rico is Gabriela Paz Bailey, chief of the Center for Disease Control and Prevention's branch of Division of Vector-Borne Diseases. Thank you all for joining us today. So according to the WHO's Dengue Global Surveillance Tracker, there have been more than 12 million reported cases this year. That's more than twice the number of cases that were recorded last year. Let's begin by taking a closer look at the global picture. Gabriela, what are we seeing?
Yes, thank you, and I'm so happy to be part of this panel. Sorry to be joining remotely. And this year has been really a big year for dengue. 12.3 million cases have been reported, and most of the cases are coming from the Americas. 2023 was a record year, and 4 million cases were reported, and now we're seeing 3 times what we saw last year. So it is really a concerning trend. In terms of the US, we have an ongoing outbreak in Puerto Rico. There was a public health emergency declared in March, and CDC stood up an emergency response to help respond to the increases in Puerto Rico and also anticipate increases in the US states. We traditionally have seen cases in states like Florida, Texas. There have been outbreaks in Hawaii. But now we're also seeing cases in new states. Arizona reported 2 cases last year. California reported 3 locally acquired cases last year. And this year also they have reported 4 from LA County and San Diego County. So we're seeing both increases in areas that have seen dengue before and also dengue appearing in new areas. And there are several reasons for this. I would like to mention 3, but I'm sure that my fellow panelists may have other things to add. One is climate change. Dengue is transmitted by a mosquito, and it has been sort of a wet year this year. And climate is helping the mosquitoes thrive in endemic areas, but again, increase its range to new areas that have not seen dengue before. For example, Brazil had its worst outbreak in history in 2024 with 8 million cases reported. And then other places like Lima in Peru that have not seen dengue before also had a huge outbreak last year in 2023. The second year is that dengue is cyclical. Dengue is caused by 4 different dengue viruses. So when you're infected with one, people are immune against that virus for life, but only have a short-term protection against the other viruses. So after everyone gets infected with one virus, immunity starts weighing down against a different serotype, and then another outbreak can occur in 2 to 5 years when a new serotype is introduced. And finally, there is more travel now than ever before. During COVID, there was less travel, and that resulted in decreases in dengue. But now with increased connectivity, we have more transmission. And humans really help the virus move around.
Okay, so Dan, we're obviously seeing a huge increase. As Gabriela explained, part of that is about the climate this year and climate change. But what else is contributing to this? I mean, are we making it too easy for the vectors to get at us?
Well, as Gabriela gave a great answer, the two fundamental determinants for transmission of dengue and other arboviruses or viruses that are transmitted by mosquitoes are, first of all, mosquitoes. So dengue, there may be a couple of instances where there's been documented sexual transmission, but it's largely a disease that has to be transmitted by Aedes mosquitoes. Aedes aegypti or Aedes albopictus are the principal vectors around the world. And then once you have mosquitoes, you need a population that is susceptible to infection, that does not have enough immunity to stop transmission and stop symptomatic disease. So sometimes you have transmission of a vector-borne disease and you see a spike, but it goes away in subsequent years. This is what happened when Zika caused a huge epidemic in 2015 and 2016 in Latin America and the Caribbean, French Polynesia, and some other places. It didn't stop because the mosquitoes went away. It stopped because people became immune to the Zika virus. With dengue, I think immunity is an important factor, and it's a complicated factor that I think we'll probably dig into during this session today. But I think factors that have been helping the mosquito populations, especially recent weather, the El Nino Southern Oscillation is a specific weather phenomenon that is cyclical, that results in enhanced rainfall and humidity in certain places, maybe drier conditions in others, but enhanced rainfall certainly is helpful to mosquitoes, especially in some parts of the Americas. The amplitude of these El Nino Southern Oscillations, where interaction of the temperature of the Pacific Ocean and trade winds produces these changes in rainfall and humidity. The amplitude of these variabilities and these interactions has been increased a little bit by climate change over time. And I think we can expect some of the highs and lows of El Nino and its opposite effect, La Nina, to continue increasing over time. So I think we can expect, these cyclical, spiky emergences of dengue to continue and to perhaps become worse as climate change effects kind of exacerbate the severity of weather that favors mosquitoes.
Thank you both for those. Marcia, it's not just climate, right? I mean, it's also the way the vectors interact with people. Mm-hmm. Talk to us a bit about that, and particularly, if you wouldn't mind, explain a bit about what's been going on in Brazil.
Yeah, so let me add two things that haven't been discussed yet. So in the context of Brazil, one of them is that when 2023 comes, Brazil is facing major difficulties to do vector control because of disruptions that happened during the COVID-19 pandemic. So going house by house and even spraying insecticides was not really happening as it should. And connected to that, it was handling a horrible government we had for 4 years that failed, for example, among many other things, to procure insecticides. So 2023 comes, we haven't been doing vector control and we have no insecticides. The second thing I want to highlight is the patterns of urban growth that we observe, not just in Brazil, in many different places. But just to give you an example, if we keep growing our cities without regular access to water, garbage collection, so in the ways that are really conducive to create mosquito breeding habitats. And just to give you some numbers, if you take the period between 1985 and 2022 in Brazil, 5% of the entire urban growth was in slum kind conditions, and 12 cities in Brazil had more than 50% of the urban growth in slum type conditions. Of those 12, all but one were in the Amazon region, a region that has been seeing an expansion of arboviruses, dengue being the main one. So it's not just climate. Climate comes, and the highest number of cases Brazil ever had before 2023 was 2015, when we had the previous worst El Nino. This El Nino comes, 2023 becomes a problem. Everybody's sending warns, 2024 can be worse. And according to the Ministry of Health, so far we have 6.5 million cases of dengue and 5,500 deaths. That's absolute record. So to me, climate interacted with this local context and really create a perfect storm. But just don't blame on climate, because those other issues are there. And you're just creating something that makes it even worse.
And can I just ask you before we move on, are we seeing similar circumstances in other parts of the Americas? I mean, dengue is primarily a problem here. Is it happening in other parts of Central and South America?
Yeah, great question. I think that those eruptions due to COVID are pretty much all over. And the patterns of urban growth, unfortunately, that's you take the global south, that's happening. So we are creating pockets of unhealthy living conditions in the cities that are growing.
Okay, wow. Guillaume, so you were the former head of Sanofi's vaccine division, and where you helped develop and launch the world's first commercially available dengue vaccine, Denvaxia. What were some of the challenges of bringing a dengue vaccine to market, and what are the challenges of bringing additional vaccines for dengue to market?
Well, thank you for the question. I do think developing a dengue vaccine is probably one of the biggest challenges in the vaccine research field for many reasons. First, it's not one virus, but four. So it's 4 different serotypes. And we know there is a limited cross-protection between the 4 serotypes and not long-lasting protection, by the way. And there is no real fully predictive animal model to replicate the dengue attributes and even less for the severe dengue, which make the preclinical work even more complicated. And last but not least, the disease itself for the patient or the disease for the population is related to the pre-immune status of the patients, which makes the situation even more complicated to really understand the way the disease is affecting. And last but not least, it has been mentioned previously, it's a vector-borne disease transmitted by mosquitoes, but there is different mosquitoes, Aegypti, Albopictus. The force of infection is not the same according to the period of the year, according to the geography, according to the age group. So there is really a lot of challenges according to the virus itself.
Right.
Once being said, regarding the vaccine development, the number one critical question is, what is the target product profile? Why do we want to prevent?
Yes.
Do we want to prevent first one serotype, and then a second one, and then a third one, and then a fourth one, and finally to combine all of them, and to add some other arboviruses, by the way? Do we want to protect immediately against the 4 serotypes?
Right.
Against which type of disease? Do we want to protect severe cases first, and not so much the mild cases? Or do we want to protect the severe cases, the mild cases, and including the transmission of the viruses? So all of these parameters should define your target product profile. Do we want to go in any age group or in a more focused group at the beginning? Do we want to go in some geographies, highly endemic countries, or just vaccinating the travelers? So there are many parameters to define, because the answer you will provide to these parameters of your targeted product profile will condition your research plan.
Right.
You will have to increase the size of the population. You will have to increase your clinical design in different countries, and it has a real impact on the timing, the costing, and the probability of success. That's the first big challenge, target product profile. And then you have a second challenge. You run your clinical trial. You generate your data, safety first, obviously, efficacy, and how it interacts with the pre-immune status of the population.
Right.
And then you have a registration with a label, an indication for your vaccine. That's the beginning of the story, because from that, you need to define your public health intervention, how you are going to make the best use of the vaccine to have the biggest public health impact. Who will be your population first? How big will be your vaccination program? Do you want to vaccinate in Brazil 200 million people in 1 year? Or do we want to do a yearly basis vaccination program? And according to the profile of the vaccine, if it's a single-dose vaccine, 2-dose vaccine, 3-dose vaccine, you could have a vaccine very good for a routine immunization, but not for an outbreak control. It's too late. The time to have the right immune response generated. So all this kind of definition together with the health authorities is absolutely essential to get the best of the vaccine and to document it. And last but not least,
Okay.
production and price. Because if you decide to vaccinate 50 million people with a 2-dose vaccine, you need 100 million doses. And to get 100 million doses produced by the industry, it needs anticipation. So you can see we have the scientific agenda, the public health agenda, the industrial agenda to be managed carefully all together at the same time. And last but not least, the price. And the price for dengue is more challenging than the price for any other vaccine, because you don't have the high-income country, north parts of the earth, able to pay and give the payback to the private industry who has been investing at risk to get a vaccine, compared to any other vaccine which have been developed first in the north and ultimately accessible 5-10 years in the south. Right. Here on dengue, we are flipping the traditional access model by giving first a priority where the public health impact will be the biggest, by giving a sustainable and affordable price to the population the most indicated.
Can I just slip in a question about sort of the experience with Dengvaxia that picks up on some of what you just mentioned? You talked about a target product profile. Do you want something to vaccinate large swaths of people in places where they're going to be exposed to dengue all the time, or travelers? The traveler market would help to sustain the cost of the production and whatnot, but those are different people who have not been exposed typically to the virus and aren't at risk of, ADE. I'm trying to work in the antibody-dependent enhancement situation here. I mean, when you are trying to vaccinate two entirely different groups of people, does it make it challenging to try to produce one vaccine?
Absolutely.
And maybe explain a little bit about ADE.
No, I think it's a very valid point. I think the severity of the dengue infection has been related to the pre-immune status, so previous infection. And the big question has been how a vaccination could mimic a primary infection. And then when you have a second infection, assuming the vaccine will not work enough, what will be the clinical profile of the second infection? So this requires a very deep analysis in the very early stage, preclinical and clinical stage, to really understand this. Because even in Brazil, you have naive population who never face the virus because they are too young, or in an area where the dengue is not yet circulating. Right. So you have naive people all over the world, and you have prime people in the endemic countries. So definitely your vaccine has to be adapted for both population, right? And the expectation will not be the same. If you are a traveler, you want to be protected against the potential infection you will get. When you are already pre-immune because you have been exposed to dengue, which is the case, a majority of people around 9 years of age in endemic areas, tropical, subtropical areas, have already been exposed to the dengue case. So that's where the effect is not completely the same. Last but not least, you mentioned the traveler as an opportunity to offset the cost. Traveler market has always been a very, very limited market compared to the massive population who is requiring now a real efficient way to prevent dengue. So that's not the same size of opportunities.
Great. So dengue was approved. I'm not certain in how much use it is Dengvaxia, excuse me. I'm not sure how much use it's being put to at this point, but there are other options. Gabriella, I was hoping you would talk to us a bit about Takeda's Kdenga and Butantan's DV vaccine. What are those? What are the prospects for those?
Yes, and I would just like to go back to your question about antibody-dependent enhancement, because it is crucial that a dengue vaccine protects against the 4 serotypes. And the reason for this is how the immune responds to dengue infections. So antibodies that are formed after the first infection to fight that infection, when the person is exposed again, actually help the virus get inside the cells, increase the viral load, and can result in severe disease. And then when the person is infected for a 3rd time and a 4th time, that risk goes down because broadly neutralizing antibodies have been developed, and then the risk of severe disease is lower. So it is during that second infection that the risk of disease is greater And if a vaccine does not provide protection against all serotypes, if a person is infected a second time, if a person is infected naturally after vaccination, then that's when there could be an increased risk if we don't have a vaccine that protects against all serotypes. So it's a very important point, Helen, and thank you for raising that. In terms of the Imvaxia, it's mainly used in the United States. It's recommended. It's only used in Puerto Rico because it's recommended for children living in endemic areas. And implementation is complicated because it needs a test, a lab test before administration, and it can only be administered to those who have had dengue before.
Can I interject with a question? Sorry, I just wanted to interject with a question. I don't think it's been used much in Puerto Rico. It might have been you who provided this piece of data, but I was listening to an ACIP meeting not that long ago, and somebody asked how many doses had been used in Puerto Rico, and the person said 109 or something like that. I don't think it's widely used, is it?
Yes, the recommendation is children 9 to 16, and the requirement of a laboratory test to be administered before providing vaccination really complicates logistics. The system is not prepared for that, right? The way that immunization programs work are not related to lab tests being offered and people getting results and then eligibility being determined. So that has really limited implementation, and right now, it's about 350 kids that have been vaccinated. So the program still has challenges. Furthermore, Sanofi has stopped production of this vaccine, so the available doses are only valid until 2026. It will not be available after that. So regarding the other vaccines, the Takeda vaccine has been recommended by WHO for children 6 to 16 in settings with high dengue transmission. So it has been licensed in several countries and has already been implemented as part of immunization programs in Argentina and in Brazil. It does not require pre-vaccination screening, so a lab test is not going to be needed before administration. Then the other vaccine was developed by NIH, TV003, and it has been evaluated by the Butantan Institute in Brazil. They're finishing phase 3 trials, and preliminary results have been published after 4.5 years follow-up. And they have shown efficacy against dengue 1 and dengue 2 in seropositives and seronegatives, but they did not have any transmission of dengue 3 and dengue 4 during the trial. So efficacy against those two serotypes is still pending.
When you were talking about the challenges of developing a vaccine, if the virus doesn't circulate, you cannot generate any efficacy data, which is very challenging for something like this. Okay, so let's circle back to the vectors. What are the most, given that vaccines hopefully will be of use and at a point, but the problem exists now. What are the most effective strategies for controlling the Aedes mosquitoes? Sure,
I can answer that. People have come up with a lot of clever and effective ways of killing mosquitoes, and this is great because in the absence of highly efficacious, widely deployed vaccines for a lot of mosquito transmitted diseases, controlling the vector has been the most important public health measure. So there's a range of different things. One of the most useful tools for controlling malaria transmission, which are bed nets, especially bed nets treated with insecticides, doesn't work so well for the Aedes mosquitoes that transmit dengue because Anopheles mosquitoes that spread malaria like to bite you at night when you're hopefully under the net, and so the net protects you from that. Aedes mosquitoes favor a snack during the daytime, and so if you're not under a net at 6 p.m., you may not benefit from that measure. But there are a lot of other approaches. Aedes mosquitoes like to breed in small containers of water or larger bodies of water in some cases, but eliminating standing water has historically been a highly effective means of reducing mosquitoes because the larvae, the immature stages of the mosquitoes, need to develop in fresh water. So eliminating larval breeding sites, distributing larvicides to control the development of mosquitoes in those sites if they can't be eliminated is also highly effective. And there are some biological larvicides that are able to target mosquitoes specifically and not kill a wide range of arthropods that kind of limit ecological impacts, but really help with human health. Of course, there's personal protection. You can wear repellents, you can have window screens, but a lot of these measures are related to the economic development of a setting and are challenging to attain in some dengue endemic regions. And of course, historically, one of the most effective ways of controlling Aedes mosquitoes has been chemical insecticides. So there's various classes of insecticides that are various levels of good at killing, various levels of effective at killing Aedes mosquitoes in different parts of the world. These can be sprayed from backpacks, from trucks, from airplanes, depending on the scale. These were deployed in Miami when there was a limited amount of Zika transmission here in the US in 2015. The issue with insecticides is that they are so effective that they engender a strong evolutionary response in mosquitoes. And so resistance to virtually all the insecticides that have ever been deployed against mosquitoes has developed and reached some level of population prevalence in different mosquito populations around the world, depending on how those control measures, how aggressively they were deployed. And so if you do that, you need to accompany those mosquito interventions with some kind of monitoring so that you're not driving those interventions into a state of uselessness by overdoing it and making the population totally resistant. And I think this underscores the need for continuing innovation in the space of mosquito control as well.
So talking about innovation, I think there's a lot of excitement about another tool that has been in the development for a while. The release of mosquitoes that are infected with something called Wolbachia, which can control transmission. Gabriela, can you tell us a little bit about Wolbachia and how that tool is evolving?
Yes, and mosquito control for dengue has been challenging because of the reasons that Dan explained. I mean, insecticide resistance is really widespread, and something as small as a bottle cap can hold more than 300 mosquito eggs. So reducing breeding sites can be very challenging as well. So in terms of novel strategies, Wolbachia replacement has shown very positive results. Wolbachia is a bacteria that occurs naturally and can be found in about 60% of mosquito species. And scientists have been able to introduce it into the Aedes mosquito and found that it blocks infection with dengue and also other arboviruses like Zika and chikungunya. So the method consists of releasing both male and female mosquitoes with Wolbachia into the environment, and the bacteria is passed to the offspring. So eventually the natural population, the local population, will be replaced by Wolbachia infected mosquitoes. There was a randomized cluster trial in Indonesia that showed 77% reduction in dengue incidence and even a higher reduction in hospitalization, about 85% reduction in hospitalization. And that was huge. So it has been implemented in 14 countries around the world with very positive results. There's some challenges related to temperature. So places that are very hot may not be the best places for certain types of Wolbachia. And I think that the challenge now is scaling up, because many of these programs have been in small areas, implemented with universities or with other partners, but we need for this intervention to be part of traditional vector control and to be fully embraced by local governments and to be implemented at a large scale in order for it to really help reduce morbidity and mortality globally.
Dan, do you have thoughts about Wolbachia?
Gabriela made a lot of great points. I think scalability is one of the challenges of this otherwise really promising and exciting, chemical-free intervention. one detail to mention is that when you release mosquitoes containing Wolbachia into a local population, their success can be determined by how genetically similar they are to that local population. How well adapted are they to live in that specific place? Because even though Aedes mosquitoes live around the world, there's lots of microadaptation that happens in every different place that they live according to the local environment. And so the success of those programs can be assisted if the Aedes mosquitoes that contain Wolbachia are bred in cages to kind of transfer those Wolbachia onto the local genetic background of mosquitoes before raising large numbers of them for release. And so that's just an example of how interesting the biology is of this intervention, but how much work is required to distribute it to lots of different places to customize and ensure the success of this intervention in different settings where the mosquitoes are different from each other, and this matters for their survival.
Before we move off of that, Gabriela was talking about the scalability being a problem. I'm wondering about affordability being a problem. I mean, if you need to do bespoke populations of mosquitoes to combat dengue here and here and here, is this an affordable option? And you probably have thoughts about this, Marcia, too. So if you want to jump in.
Yeah, I can say a few words about what Brazil has been doing. So they started doing deployment of Wolbachia mosquitoes with the World Malaria Program in 2017. And they have built a different sort of industrial plants to breed those mosquitoes. It's not a simple operation. It takes time. And there's one particular city. So when they started in 2017, it was only 5 cities. And then this year, they expanded to another 6. In the middle of the hurricane, which is not going to be a lot of effect anyway in terms of cases. But Brazil has 5,570 of those. So just to put in context the scalability, one of those cities started earlier because it's in Rio, and Fiocruz was leading this. It's a city called Niterói. It's about 500,000 people living in there. They started in 2015. They deployed for 8 years, and they stopped when it basically showed that 100% of the mosquito population carried Wolbachia. Then comes 2023, 2024, they had the lowest number of cases on record. And just to compare with the capital city of the state, their incidence was like more than 6 times lower than the capital. And why do you still have some people infected? Well, people could get dengue anywhere because they go to Rio to work and so on and so forth. But the scalability is still an issue. And other things, there's this phenomenal documentary that was done about the deployment of those mosquitoes in Brazil. When you go to a community or a slum type area, people are very skeptical. What are you doing here? Are you going to release those mosquitoes? Why? What are you going to do this? We're always the ones suffering with those things you were doing. So there's an issue of trust. And how much people are gonna, keep seeing those mosquitoes being delivered every week, and when are the results gonna come?
And they're still getting bitten.
And they're still getting bitten. Yeah, that's that too.
You're absolutely right.
Yeah.
Wow, that it's astonishing. Is the thought that eventually you could just drive out the native population, the dengue, the mosquitoes that can transmit dengue, or do you think over time you would need to replenish the population because the mosquitoes would come back?
Well, to me, I can give my 2 cents and you can give yours, but I think the whole issue of vector control is if you don't do it everywhere, things are going to come back. So Brazil is doing those cities, 10, 11 cities. If there's no way to scale up, and then you stop because 100% of the population carried Wolbachia, and they can come back. And we've seen this with different diseases, like how many countries have eliminated malaria and then it came back, right? So the issue is how can you sustain this in the long run? So places that have achieved the Wolbachia presence will continue to be that way. And to me, that's completely related to scaling up those things.
Okay. It also sounds like surveillance is a key here. You were talking earlier, Dan, about the fact that mosquitoes become resistant to the chemicals that are used against them. Clearly, you have to do surveillance for that. Clearly, you have to do surveillance to monitor how much Wolbachia control you have in a given time. How is that done? And is it done well enough?
Sure. Well, I mean, one of the most useful tools is genetic analysis, because we know a lot of the DNA mutations in the genome of mosquitoes that confer resistance to insecticides, and we can also do genetic tests to detect whether Wolbachia is present in mosquitoes and at what prevalence in a population. And I think, as Gabriela mentioned, there have been some locations where Wolbachia infections have disappeared from Aedes populations, where they've been established perhaps due to temperature events or selective pressures on mosquitoes that have affected that relationship between Wolbachia and mosquitoes in ways that we don't completely understand. We don't completely understand why Wolbachia infection makes Aedes mosquitoes less effective at transmitting viruses. It's just it's a wonderful thing that happens, and there's a lot of potential mechanisms that we're still sorting out. So without fully understanding the biology, I think some vigilance and surveillance is required to make sure that those Wolbachia stay resident in local populations, and to be able to notice when they disappear, so that perhaps we can better understand the circumstances that don't favor their persistence.
Okay, great.
And if I may add to that, to complement what Dan is saying, the Wolbachia genome seems to be very stable and has been in nature for many, many years. The Aedes aegypti genome seems stable as well, but I think that the crucial part is to monitor the virus, because the data right now show that it blocks all 4 serotypes in the trial in Indonesia, but it may be that we get certain genotypes that are not equally blocked by Wolbachia. So maintaining human surveillance and understanding what genotypes are circulating and if there is a difference in efficacy is going to be crucial for the long-term monitoring of the impact of this strategy.
Thank you. That's a fascinating point. So when Marcia was talking earlier about use of dengue in Puerto Rico, she talked about the fact that it's a difficult vaccine to administer because you need to do the test in advance. It doesn't really fit with the way public health vaccines are given in general. Is that true for other dengue control measures? And are we able to sort of integrate them into public health programs, or do they sort of sit in their own space, causing their own challenges?
Yeah, so I think one missing link is the lack of connection with other sectors of the government. So I mentioned the regular access to water, garbage collection, urban growth. So in this imaginative scenario that you can release those mosquitoes everywhere and every single mosquito has Wolbachia, transmission goes down, the root cause of the problem is still there. And this affects other diseases as well. So to me, bringing other sectors and addressing some of those problems that are actually the source of a lot of inequities should be part of the dengue control program. And you would benefit not just the reduction of dengue, but other things as well. So to me, that's one of the missing links.
Okay.
And if I may,
Yes.
we have to keep in mind, it's not, I used to say it's a bit an image, but it's not the mosquito transmitting the disease to the human. It's the human transmitting the disease to the mosquito. It's still a lot, because the mosquito don't like to travel too much. Compared to the human, who like to do kilometers and kilometers to go from one place to another place. So that's a very important point for the spread of the outbreak. The second aspect, we spoke a lot about Aedes aegypti, not so much about Aedes albopictus.
Mm-hmm.
Albopictus is supposed to be less good in transmitting the virus. But there is many places in the world where you have a lot of albopictus, not yet outbreak of dengue. And it's something we have to monitor, obviously, because according to the adaptability of the virus with the host and the population, you could have a number of cases raising in such an area. And last but not least, there is not one solution for everything. That's very, very clear. At the beginning, when the first vaccine research has been progressing, people say, oh, we are going to stop the vector control. No, not at all. Vaccine is to prevent infection on a long-term perspective by generating efficacious and safe immune response, right? Vector control is really to reduce the number of vectors able to affect in an epidemic condition a large population, and it has to be coordinated from anticipation, intervention, vaccination, and vector control. It has to be all together on a long-term perspective, not just because there is an outbreak, we do everything we can, and 6 months after we forget it and we restart the year after.
Okay. Wow. Well, this has been fascinating, and I think we've covered a lot of ground, but we're running out of time. So I was going to ask each of you to sort of give us a takeaway, closing thought. And if somebody could say something hopeful, that would also be wonderful. Let's start with you, Marcia.
All right. So to me, my 2 cents is surveillance. So if we have a good surveillance, both epidemiological and entomological network, that brings together the environmental data together, that's the way to predict, prevent, respond, and be able to manage some of those increases in transmission. So surveillance as an intervention in public health is absolutely crucial.
Okay, great. Gabriella, over to you. Final thoughts, please.
Yeah. Well, I am optimistic. So I'm going to give you the optimistic note here. I mean, after years of not having really effective tools, mosquito control being limited by insecticide resistance, I think we now have important and effective tools available. So we have Wolbachia replacement that, as discussed, is not a solution for everywhere. It's intended to large urban areas where most of the population at risk is concentrated, and we have vaccines. So I think that those tools can really help us reduce morbidity and mortality due to dengue. But we really need for different groups to be involved. We need to have a concerted initiative against dengue, because we need to be able to make the case to governments to incorporate Wolbachia into their routine vector control. We need ways to finance these interventions. We need community engagement so that we can clearly explain the risks and benefits of these strategies. But I think it is a time for change, and that we can really make a difference on dengue prevention with the new tools that are available.
Thank you. Dan, to you.
Sure. My optimistic take on dengue is that despite the morbidity and mortality that this terrible disease causes worldwide, it does remind us that we're connected to this planet. A lot of us kind of think of ourselves as being insulated and living in a space separate from nature. But we're animals. We're infected by these viruses that jumped to humans from monkeys 4 different times, that are now transmitted around the world by mosquito species that were originally from Africa and Asia, and whose ranges are continuing to expand as the climate changes and as weather becomes more unpredictable. So I think dengue reminds us that the way we develop our cities, the way that we think about climate is related to our own prosperity, and that we're connected to the ecology of this planet.
Final word to you, Guillaume.
Thank you. Well, the bad news of today is the epidemiological situation. It has been extremely clearly mentioned, and the number of the cases are really rocketing now, and it's a systematic yearly epidemic affecting millions of people. That's the bad news of the day. The good news is for the last 3 decades, we have been able to make dengue a vaccine-preventable disease. There is not 1, but 2, 3 vaccines in research and development and arriving to the market now. So I join Gabriella on the hope and positive mindset, because we have now access to new tools on top of the innovation made in the vector control plan. So my last comment is let's work together, let's consolidate all of that together to bring this best solution together, because providing a dengue prevention for population exposed to this disease, it's a real game changer for this population. It's a real societal commitment we have to take to provide a solution for the population the most exposed. It's what I used to call an inclusive innovation to reduce the gap between the non-endemic areas and the endemic areas. So please, no give up today. Let's move forward. We are much better than 30 years ago, and I'm sure we could find a way to minimize the burden of the disease all over the world.
So thank you very much to our esteemed panelists, and thank you and the audience online for being here today. To the online audience, if you've missed any part of the discussion or you want to rewatch it, the recording of this session will be posted to the Harvard T.H. Chan School's YouTube page soon. Have a great afternoon. Thank you very much.